एते अनभिज्ञ अज्ञ आउ किछि परिमाण मूर्खता जदि देखा आम जीवनटा सहज और सुंदर केमती समस्या आज डेट्रे समाज जी लोक पीड़ित अच्छा आम जदि एवं पचारे किए एफेक्टेड किए असुविधा अच्छा समस्या उल्टा बोधे पचारे पड़ो कौ मैंने भलरे अच्छा मांसपेशी कौन जंत्रणा ना डायबिटीज हार्ट प्रॉब्लम कौन समस्या ना ऑटो इम्यून डिजॉर्डर किसी ना कहार संपूर्ण भाव स्वस्थ अच्छा बहुत कम लोग आम तो दिने ना दिने मरवा किंतु असहाय अक्षम बा अन्य उपरे निर्भरशील होगी जंत्रणा पीड़ित होगी कलमन होगी आमर अंत हवा दरकार कि डिसेबिलिटी एडजस्टेड लाइफ इयर्स ये गोटे कैलकुलेट कराई गुड़ाए लोक जो अंत हो समस्या एमती भाव में हैंडल हो विभिन्न प्रकार शल्यक्रिया विभिन्न प्रकार औषधीय उपचार आ हॉस्पिटल आईसीयू भितर रखिकी शेष जीवनटा दुखमय जंत्रणामय हो रही आम चाहूले अनायास ने मरण बिना दैन्य जीवन यह आम परंपरा थी डेथ आसो इजी डेथ पीसफुल डेथ आते बर्त लाइफ अच्छी वेरी हेल्थी लाइफ वेरी हैप्पी पैशनेट लाइफ एटा वर्तमान हे पारू नाही
लाइफ रे से हठात अनकॉन्शियस समस्ते आश्चर्य हेले विव्रत हेले बोधे किसी हार्ट अटैक होगला कि कौन होगला कि प्रकार जो हैदराबाद एयरपोर्ट रे ओल्ल सागे सागे डाक्तरखाना को निगला सब प्रकार परीक्षा निरीक्षा करागला हार्ट सब ठीक थी लंग्स ठीक थी ब्रेन भी ठीक थी देखला बेलू कौन ना कानर गोटे समस्या है कानर जो इम्बालांस जो से हठात सेन्स हर अचेत से समस्या को समाधान करागला एवं से समस्या को समाधान करने समय अन्य क्षेत्र रोग था यथा आजमा थी से आजमा भल होगा केमती तार संपर्क कौन मुझे जाने ना मु तो डाक्तर नुहे किंतु यहाँ हूँ मोर गोटे अभिज्ञता से कहली जेहेतु ये डाक्तर मैंने अच्छा विशेषज्ञ मैंने अच्छा लोक मैंने अच्छा मोर अभिज्ञता गोटे जिन आप आगे परिवेशन करी गोटे द्वितीय अभिज्ञता मोर बापा केस मो बापा गोटे प्रोब्लेम था पिला कानर ऑपरेशन होता से शुणी पारती अधा शुणु आम जिते कहू कि तुम्हें गोटे किसी जंत्र लगा शुणा जंत्र जो जंत्र आनी लगे से जंत्रटा एत शब्द है सी लगे चाहिए आमको उल्टी कहले जीवन में शांति बचापी हेले किसी कम शुणा भल ना खाली समस्या तुम शुण तुम कम शुणिले किसी असुविधा ना ये गोटे द्वितीय उदाहरण तेरे शुणु मोर कह जोटा कि कहते प्रोफेसर महापात्र जे जीवन में बंची रही आमर जिते इंद्रिय अच्छे सब गुड़ाक ठीक भाव में काम करवा दरकार सब इंद्रिय ठीक भाव में काम कले ही आमर मनटा ठीक भाव में काम करे आम शरीर से अनुसार ठीक भाव में परिचालित हो जदि आम भाविबा जे देह खराब कहले केवल हार्ट प्रॉब्लम है देह खराब कि किडनी प्रॉब्लम है देह खराब किंवा पैंक्रियास प्रॉब्लम हेले देह खराब अन्य प्रॉब्लम तो किसी देह खराब में जाए नहीं ताहले आमे जानी सुनी निजकू गोटे अर्ध मनुष्य करिके आमे रखिछे बोली कहबा जीवन को जेभली भाव में आमे उपभोग करने कथा जीवन को जेभली भाव में हमको व्यवहार में लगेगा कथा आमे से ठीक भाव में करना बोली हमको मानिया से यही जो कर्मशाला ये प्रोफेसर महापात्र को कहते जे आज गोटे अकेजन में आप भल कथा किंतु आहरी आहरी लोक पाखक जावा उचित कारण लोक विषय लोक मान विषय ज्ञान ना से आड़े हुए आसिक आपण शुणापी इच्छा प्रकाश करेंगे ना कारण से जानते ना जे गोटे संस्था अच्छी एत सुंदर संस्था एत सुंदर कार्य कथा मुझे जाने किंतु अन्य मैंने हूँ जानी ना जानवर अवकाश ना जानवर इच्छा न थी तेणु जो कथार अच्छी मोहम्मद यदि पर्वत पाख को न जाती तेल पर्वत को जावाक पड़ो मोहम्मद पाख तेणु आपण मानक जावाक पड़ो लोकों पाखक विभिन्न उपाय स्कूल को रेसिडेंट वेलफेयर एसोसिएशन एवं विभिन्न ये आम संस्था सब रही से माध्यम लोक को जनइबा पड़ो जे कौन कले आम गोटे पूर्णांग जीवन यापन कर आमर शुणा कथा हो कि अन्य जेको विषय हो आमर सब ठीक भाव में आम इंद्रिय काम करूँ आम सब फैकल्टी ठीक भाव में काम करूँ यही जो काम करने कौन करने हम कि प्रकार पदक्षेप नापी हम कौ समय से पदक्षेप नाक हम ये सब विषय लोक को सचेतन कर आवश्यकता रही मोर दृढ़ विश्वास ये IHS जो भाव में निरवच्छिन्न भाव में लोक सेवा करके लोक मन में आशार जो प्रेरणा सृष्टि कर आगामी दिन मान रख लोक मान बर्तमान जो प्रकार दुख भितर से बढ़ी से दुख को लाघव कर पुण्य काम आपने कर प्रोफेसर महापात्र सहित जो मैंने सहयोगी समस्त हृदय
But vertigo is not a disease. So everybody should remember vertigo is not a disease, it is a symptom. Patient may describe like spinning sensation, melting sensation or unsteadiness or lightheadedness or dizziness or giddiness. These terminology usually we face when we see the patient. Okay? The only common feature is feeling of uncertainty of the position or motion of the body. So this is the basic thing when you deal with a patient. So it is a really a distressing problem, not only for patient and his family, but also for a treating doctor. Patients even run from general physician to neurologist, ophthalmologist, ENT surgeon, physiotherapist, and try to seek remedy, and finally sometimes they landed in psychiatrist clinic also. So what is the impact of this vertigo? It has a lot of impact in the daily routine life. It is a patient frequently need medical consultation. If patient not treated properly, patient goes frequently to clinic, and patient most of the time are anxious because they think they may be suffering from brain tumors or any intracranial problems. And the recurrence is usually 80% in many cases of vertigo, and there is a frequent patient or student or if patient need a sick leave most of the time, and it will cause a reduced quality of life. So it is a very very important, it will affect our daily and skillful life. So how it is affecting the quality of life and the routine work. So one more recent research showing that a vertigo is not only quality of life and imbalance, there is some cognitive issue. Cognitive issue means there is some like memory, attention, also these are affected. Because those are, we will discuss how the vertigo occurs. Vertigo occurs, we know there is a defect in the vestibular ocular pathway or vestibulocerebellar or vestibular or spinal, this pathway is when affected, we think it is a cause vertigo. But some pathway is still not researched, like vestibular from nucleus to the orbital cortex, vestibular cerebral. These pathway not much studied, but these may be responsible for cognitive issue. So vestibular dysfunction may lead to degeneration of a particular vestibular network regions and adversely affect synaptic plasticity and neurogenesis in hippocampus, which is a very important part of the brain, and ultimately contribute to neuronal atrophy and cell death, leading to memory and a visuospatial deficit. So vertigo has a lot of prolonged. Those patients, those are suffering from prolonged vertigo, they are also prone for suffering from memory loss and lack of attention. Many things. These are cognitive issues now currently studied. So epidemiology point of view or prevalence, it is a 5 to 10% world population are affected by vertigo. It is the fourth most frequent complaint in men and seventh most frequent complaint in women. So how it occurs? Balance is a very, very important part of human being. So balance or equilibrium may be defined as the capacity to maintain posture and spatial orientation at rest and during movement. The sensory input from maintenance of equilibrium comes from three sources, like visual or vision, somatosensory and vestibular. We get sensory input from these three things, and it will at rest or on stimulation, the apparent information from these three systems is coordinated and processed in the central nervous system to recognize the subject's position or displacement. Finally, motor output is generated which affects the necessary alteration in the muscle to maintain equilibrium. So, this is the basic physiology of any science student. They know how the balance is maintained. So, visual proprioception and from inner ear, these three parts is responsible for maintaining sensory input from outside to the brain. The motor output is directed to the skeletal muscles in the limb, neck and trunk, and extraocular muscles through vestibulospinal and vestibulo-ocular reflex. The timing, preciseness and accuracy of the muscular contraction, both skeletal as well as that of extraocular muscle, is the function of cerebellum. So the fineness of a muscle contraction or motor execution is decided by cerebellum. So what is vertigo is nothing but it is a hallucination of the movement. There is a hallucination of movement that can be applied to any movement provided that it does not exist outside its sense of a sufferer. There is no movement of a tree and a house, but patient feels something is moving around it. So it is a hallucination. So it is an illusion of movement. Everything is spinning or moving and can arise from visual or vestibular apparatus central lesions. So this is the vertigo. When patient of vertigo attend clinic, it is always challenging for a clinician. So we decide, is it really vertigo or not? So this is the first question, is it really vertigo or not? If vertigo, it is due to central cause or peripheral cause or vestibular cause. Then question will come, how much severe? Then we will think about management. So we divide the DG patient into 4 categories. Dizziness type 1. It is a true vertigo. It is essentially a vestibular problem, either peripheral or central connection. Patient describes spinning or definite rotatory feeling precipitated by fast head movement, getting up or lying down, or even turning in bed. From this history, we think it is a true vertigo, and usually it is a vestibular problem. It is a type 1 category we include. Next is type 2, where it is a cardiovascular cause. Patient present with faintness or darkness before his eyes when upright or getting up. So we should not confuse. So this is pre-syncope or syncope. So causes postural hypotension. So check between supine and standing position. If systolic more than 20 decibel and diastolic more than 10 decibel, usually you tell it a postural hypotension. And vasovagal attack, hyperventilation, low cardiac output. These are not true vertigo, but patients come with this type of presentation. So all these anti-vertigo drugs will not work. So we should take this. This is a dizziness type 2. Dizziness type 3, it can be described as unsteadiness or incoordination of the gait or feeling of loss of balance. This is a neurological disease. Typically occurs when a patient stand up or walk and is motion by uneven ground or turning. It never occurs when sitting or lying in bed. Mostly neurological disease like gait ataxia, Parkinsonism, cerebral ataxia, multiple sclerosis. So these are not true vertigo. These are imbalance, but these are not true vertigo. So this is a dizziness type 3 we include. Next is dizziness type 4, where patient usually psychogenic presentation, abnormal head sensation, not fitting into other 3 categories. Patient may present vague or describe numbness or heaviness or lightheadedness, light feeling in the head. Patient has a lot of anxieties, tension, insomnia, profuse sweating and so these are the presentation associated with the psychogenic type of vertigo. So this is a dizziness type 4. All clinical tests like positional test, checking BP and other balance tests are negative. No nystagmus and no hearing loss. So these are dizziness patient can be classified into 4 categories. So some triggering factor, when we take history, some triggering factor we should ask to the patient, like if vertigo when turning in the bed, it indicating benign paroxysmal positional vertigo. If suddenly patient present vertigo when suddenly get up, it is in favor of postural hypotension. Or when patient feeling imbalance during walking or turning, it is type 3 or balance disorder neurological cause. When patient present with dizziness, when tired or stressed out, it is in favor of type 4 or psychogenic. So these things we keep in mind when dealing with patient. And certain important features suggesting central cause of vertigo. Some intracranial cause, how will rule out, because when we deal with the patient, our challenge is to rule out central cause, to rule out intracranial cause. So how to get that? Certain features like diplopia, dysarthria, dysphagia, dysphonia, dysmetria, dysesthesia, drop pattern. These features will present. Always send the patient for MRI or send to the neurologist. Refer to the neurologist because it is in the favor of central cause of vertigo. So these are red flag signs. So on examination we will see the nystagmus is a vertical type and there are changing for direction changing, sudden onset usually, and patient may present with a headache, particularly occipital headache with vertigo. So it is in favor of central cause, or stroke may be there. So these things we should need urgent referral to the emergency department or neurologist. So how to diagnose vertigo from the duration? If patient present with vertigo only for few second to minute, less than 1 minute, it is in favor of benign paroxysmal positional vertigo. If patient present with minutes to hour, like 20 minutes to 20 hours, it is in favor of Meniere's disease. So clustering of attack with period of remissions are typical features of Meniere's disease. In case of labyrinthitis and vestibular neuronitis, the vertigo stay for few days to few weeks. It is settled down by central compensatory mechanism. If patient taking vestibular toxic drugs, some aminoglycoside group or some autotoxic groups are there, if patient may present with vestibular problem, and if the duration is from few weeks to or even month. So vertigo caused by labyrinthine disorder usually short, and though it may recur, when vertigo arising from central or brainstem or intracranial disorder is often persistent and accompanied by other signs of brainstem dysfunction. So from onset, how vertigo start? Acute, if it is acute onset, unprecipitated short-lived episode associated with nausea and vomiting indicate peripheral vestibular disorders. If the onset is insidious, protracted, would indicate central cause. Then what are the precipitating factors? In benign paroxysmal positional vertigo, it is the most common peripheral vertigo. Benign paroxysmal positional vertigo is the most common cause of peripheral vertigo. So we should rule out first. This vertigo is precipitated by particular position of the head or by changing the posture, like getting up from the bed after lying down. Vertigo in central positional vertigo is also precipitated by change of posture, but doesn't die down if the same position is maintained. And patient present with labyrinthine fistula in chronic otitis media tend to get vertigo if you press the tragus or this is called fistula side. Tragus pressure is applied on the pinna. So these are small things. It will give you the diagnosis cause of the vertigo. One interesting problem is tulio phenomenon. Here patient present with vertigo on exposure to loud noise. So particularly it is seen in post-stapedectomy surgery or thin labyrinth or even after in case of linear surgery. There are some associated symptoms. A vertigo patient when come to us, always you send for hearing assessment. So hearing loss with vertigo seen in Meniere's disease. So Meniere's disease, there is a sensorineural type of hearing loss. It may begin in 1 year at low frequency, leading to sensorineural hearing loss across all frequency involving both ears. So Meniere hearing loss with vertigo is in Meniere's disease. Another is labyrinthitis, acute viral labyrinthitis, patient present with unilateral partial or complete sensorineural hearing loss with short onset. But in case of vestibular neuronitis and a benign paroxysmal positional vertigo, there is no hearing loss. So these are history you have to take. Acoustic neuroma or vestibular schwannoma or brain tumor is present with also vertigo, but here patient usually present with unilateral sensorineural hearing loss.